Good day. We will deliver the assigned topic for us, the central nervous system drugs. I am Laika Agojo, together with my groupmates, Shikaina Alava and Akimi Alimonsurin. The central nervous system, or the CNS drugs, agents that act on the brain and spinal cord, are used for medical and non-medical purposes. Medical applications include relief of pain, suppression of seizures, production of anesthesia, and treatment of psychiatric disorders. CNS drugs are used non-medically for their stimulant, depressant, euphoriant, and other mind-altering abilities. In contrast to the peripheral nervous system, in which only three compounds, the acetylcholine, norepinephrine, and epinephrine, serve as neurotransmitter. The CNS contains at least 21 compounds that serve as neurotransmitters. The blood-brain barrier impedes the entry of drugs into the brain. The passage across the barrier is limited to lipid-soluble agents and to drugs that cross by way of specific transport systems. Protein-bound drugs and highly ionized drugs cannot cross. The barrier protects the brain from injury by potentially toxic substances. Tolerance is a decreased response occurring in the course of prolonged drug use, and physical dependence is a state in which abrupt discontinuation of drugs will precipitate in a withdrawal syndrome. The Parkinson's disease PD is a slowly progressive neurodegenerative disorder. The motor symptoms result from damage to the extrapyramidal system, a complex neuronal network that helps regulate movement. When extrapyramidal function is disrupted, dyskinesis or disorders of movement result. The dyskinesis that characterize PD are tremor at rest, rigidity, postural instability, and bradykinesia or the slowed movement. In severe PD, bradykinesia may progress to akinesia, complete absence of movement. So, as you can see in our figure, in people with PD, neurotransmission is disrupted primarily in the brain striatum. As indicated, proper function of the striatum requires balance between two neurotransmitters, dopamine and acetylcholine. Dopamine is an inhibitory and transmitter, and acetylcholine is an excitatory. The neurons that release dopamine inhibit neurons that release gamma-aminobutyric acid or GABA, another inhibitory transmitter. In contrast, the neurons that release acetylcholine excite the neurons that release GABA. PD, there is an imbalance between dopamine and acetylcholine in the striatum. As you can see in letter B, as noted, the imbalance results from degeneration of the neurons in the substantia nigra that supplies dopamine to the striatum. In the absence of dopamine, the excitatory influence of acetylcholine goes unopposed, causing excessive stimulation of the neurons that release GABA. Overactivity of these GABAergic neurons contribute to the motor symptoms that characterize PD. That being said, from 70% to 80% of these neurons must be lost before PD becomes clinically recognizable. Given the neurochemical basis of Parkinsonism, too little striatal dopamine and too much acetylcholine, the approach to the treatment is obvious. Give drugs that can restore the functional balance between dopamine and acetylcholine. To accomplish this, there are two types of drugs are used. First is the dopaminergic agents, drugs that directly or indirectly activate dopamine indicator receptors, and two is the anticholinergic agents, drugs that block receptors for acetylcholine. Is the most effective drug for PD. At the beginning of treatment, about 75% of patients experience a 50% reduction in symptom severity. Levodopa reduces symptoms by increasing dopamine synthesis in the striatum. Levodopa enters the brain via an active transport system that carries it across the blood-brain barrier. Once in the brain, the drug undergoes uptake into the remaining dopaminergic nerve terminals that remain in the striatum. Following uptake, levodopa, which has no direct effects on its own, is converted to dopamine, its active form. As dopamine, levodopa helps restore a proper balance between dopamine and acetylcholine. Conversion of levodopa to dopamine is depicted in. As indicated, the enzyme that catalyzes the reaction is called decarboxylase because it removes carboxyl group from levodopa. The activity of decarboxylases is enhanced by pyridoxine or the vitamin B6. So why is PD treated with levodopa and not with dopamine itself? There are two reasons. First, dopamine cannot cross the blood-brain barrier. As noted, levodopa crosses the barrier by means of an active transport system. A system does not transport dopamine. Second, dopamine has such a short half-life in the blood that it would be impractical to use even if it could cross the blood-brain barrier. Levodopa is administered orally and undergoes rapid absorption from the small intestine. Carbidopa has no therapeutic effect on its own. However, carbidopa inhibits decarboxylation of levodopa in the intestine and peripheral tissues, thereby making more levodopa available to the CNS. Of carbidopa, about 98% of levodopa is lost in the periphery, leaving only 2% available to the brain. Why is levodopa lost? Primarily because decarboxylases in the gastrointestinal, the GI tract, and peripheral tissues convert it to dopamine, which cannot cross the blood-brain barrier. When these decarboxylases are inhibited by carbidopa, only 90% of levodopa is lost in the periphery, leaving 10% for actions in the brain. Alzheimer's disease or the AD. Alzheimer's disease or AD is a devastating illness characterized by progressive memory loss, impaired thinking, neuropsychiatric symptoms such as hallucinations and delusions, and inability to perform routine tasks of daily living. This neuronal damage is irreversible, so AD cannot be cured. Drugs in current use do little to relieve symptoms or prevent neuronal loss. The underlying cause of AD is unknown. Scientists have discovered important pieces of the AD puzzle but still don't know how they fit together. It may well be that AD result from combination of factors rather than form a single cause. For AD is advancing age. In 90% of patients, the age of onset is 65 years or older. The only other known risk factor is a family history of AD. Being female may be a risk factor. However, the higher incidence of AD in women may occur simply because women generally live longer than men. Other possible risk factors include head injury, low educational level, production of ApoE4, high levels of homocysteine, low levels of folic acid, estrogen and progestin therapy, sedentary lifestyle, and nicotine in cigarette smoke. Alzheimer's disease progresses relentlessly from mild to moderate to severe. Symptoms typically begin after 65 years but may appear in people as young as 40 years. Early in the disease, patients begin to experience memory loss and confusion. They may be disoriented and get lost in familiar surroundings. Judgment becomes impaired and personality may change. As the disease progresses, patients have increasingly difficulty with self-care. From 70% to 90% eventually develop behavioral problems, wandering, pacing, agitation, and screaming. Symptoms may intensify in the evening, a phenomenon known as sundowning. In the final stage of AD, the patient is unable to recognize close family members or communicate in any way. All sense of identity is lost and the individual is completely dependent on others for survival. Drugs for cognitive impairment. Ideally, the goal of AD treatment is to improve symptoms and reverse cognitive decline. Unfortunately, available drugs can do this. At best, drugs currently in use may slow loss of memory and cognition and prolong independent function. 4 drugs are approved for treating AD dementia. 3 of the drugs, donepezil, galantamine, and rivastigmine, are cholinesterase inhibitors. The 4th drug, memantine, blocks neural receptors for N-methyl D-aspartate or the NMDA. The cholinesterase inhibitors were the first drug approved by the FDA to treat AD. In clinical trials, these drugs produce modest improvements in cognition, behavior, and function, and slightly delayed disease progression. Cholinesterase inhibitors prevent the breakdowns of acetylcholine by acetylcholinesterase and thereby increase the availability of acetylcholine at cholinergic synapses. In patients with AD, the result is enhanced transmission by central cholinergic neurons that have not yet been destroyed. Cholinesterase inhibitors do not cure AD, nor they stop disease progression, although they may slow progression by a few months. Memantine is a first-in-class NMDA receptor antagonist. Unlike the cholinesterase inhibitors, which can be used for mild AD, memantine is indicated only for moderate or severe AD. Memantine modulates the effect of glutamate, the major excitatory transmitter in the central nervous system at NMDA receptors, which are believed to play a critical role in learning and memory. The NMDA receptor, a transmembrane protein with a central channel, regulates calcium entry into neurons. Building a glutamate to the receptor promotes calcium influx. Multiple sclerosis, MS, is a chronic inflammatory autoimmune disorder that damages the myelin sheath of neurons in the central nervous system, the CNS, causing a wide variety of sensory, motor, and cognitive deficits. Initially, most patients experience periods of acute clinical exacerbation relapses, alternating with periods of complete or partial recovery. The pathologic hallmark of MS is the presence of multifocal regions of inflammation and myelin destruction in the CNS, the brain, spinal cord, and optic nerve. Because of demyelation, axonal conduction is slowed or blocked, giving rise to a host of neurologic signs and symptoms. As inflammation subsides, damaged tissues is replaced by astrocyte-derived filaments, forming scars known as sclerosis, hence the disease name. There are 4 subtypes of MS: relapsing, remitting, secondary progressive, primary progressive, and progressive relapsing, defined by the clinical course that disease follows. The relapsing remitting MS. This subtype is characterized by recurrent, clearly defined episodes of neurologic dysfunction, relapses separated by periods of partial or full recovery. The secondary progressive MS. This subtype occurs when a patient with relapsing remitting MS develops steadily worsening dysfunction with or without. The primary progressive MS. In this subtype, symptoms grow progressively more intense from the outset, although some patients may experience occasionally plateaus or even temporary improvement. The progressive relapsing MS. This subtype, which is rare, looks like primary progressive MS but with acute exacerbations superimposed on the steady intensification of symptoms. The disease-modifying drugs can decrease the frequency and severity of relapses, reduce development of brain lesions, decrease future disability, and help maintain quality of life. In addition, they may prevent permanent damage to axons. However, it is important to note that although these drugs can slow disease progression, they do not work for all patients. Those with relapsing remitting MS benefit most. There are two main groups of disease-modifying drugs, the immunomodulators and immunosuppressants. Interferon beta and glatiramer are administered by self-injection IM or sub-Q, and dimethyl fumarate, fingolimod, and teriflunomide are administered PO. Natalizumab is administered by IV infusion in a special center. Interferon beta is naturally occurring glycoprotein with antiviral, antiproliferative, and immunomodulatory actions. Dimethyl fumarate can decrease the body's response to live virus vaccines. Patients should not receive live virus vaccine when taking this drug. Glatiramer is less well tolerated than interferon beta and requires more frequent injections. The methoxantrone suppresses immune function more strongly than the immunomodulators but is also more toxic. Accordingly, the drug is generally reserved for patients who are unresponsive to or intolerant of an immunomodulator. The term epilepsy refers to a group of chronic neurologic disorders characterized by recurrent seizures brought on by excessive excitability of neurons in the brains. Symptoms can range from brief periods of unconsciousness to violent convulsions. Patients may also experience problems with learning, memory, and mood, which can be just as troubling as their seizures. The term seizure and convulsions are not synonymous. Seizure is a general term that applies to all types of epileptic events. In contrast, convulsion has a more limited meaning, applying only to abnormal motor phenomena, for example, the jerking movements that occur during a tonic-clonic attack. Seizures are initiated by synchronous high-frequency discharge from a group of hyperexcitable neurons called a focus. A focus may result from several causes including congenital defects, hypoxia at birth, head trauma, brain infection, stroke, cancer, and genetic disorders. Seizures can occur when discharge from a focus spreads to other brain areas, thereby recruiting normal neurons to discharge abnormally. Seizure can be divided into broad categories: partial or focal seizures and generalized seizures. In partial seizures, activity undergoes a very limited spread to adjacent cortical areas beyond the focus. In generalized seizures, focal seizure activity is conducted widely throughout both hemispheres. EEDs act through 5 basic mechanisms: suppression of sodium influx, suppression of calcium influx, promotion of potassium efflux, blockade of receptors for glutamate, and potentiation or increase of gamma-aminobutyric acid or the GABA. The AEDs can be grouped into 2 major categories: traditional AEDs and newer AEDs. The traditional group has 7 members. The group of newer AEDs have 15 members. Both groups have their advantages and disadvantages. For example, clinical experience with the older AEDs is more extensive than with the newer ones, and the older drug costs less. Both facts makes the older drug attractive. However, the older AEDs also have drawbacks, including troublesome side effects and complex drug interactions. AEDs. Phenytoin. The drug is active against partial seizures as well as primary generalized tonic-clonic seizures. Phenytoin causes selective inhibition of sodium channels. The fosphenytoin is a prodrug that is converted to phenytoin when metabolized. Carbamaxipine is commonly used for epilepsy therapy, and valproic acid is an important AED used widely to treat all major seizure types, used for bipolar disorder and migraine headache. Phenobarbital, one of our oldest AEDs, is effective and inexpensive, and it can be administered just once a day. Antiepileptic drug: oxcarbazepine, lamotrigine, gabapentin, pregabalin, levetiracetam, topiramate, tegabine, zonisamide, felbamate, lacosamide, rufinamide, ezogabine, eslicarbazepine, and perampel. Spasticity refers to a group of movement disorders of CNS origin. These disorders are characterized by heightened muscle tone, spasm, and loss of dexterity. The most common causes are multiple sclerosis and cerebral palsy. Other causes include traumatic spinal cord lesions and stroke. Spasticity is managed with a combination of drugs and physical therapy. For drugs, baclofen, diazepam, dantrolene, and tizanidine can relieve spasticity. Baclofen, diazepam, and tizanidine act in the CNS, and that dantrolene acts directly on skeletal muscle, and diazepam is a member of benzodiazepine family. Although diazepam is the only benzodiazepine labeled for treating spasticity, other benzodiazepines have been used off-label for this purpose.
Local anesthetics. Local anesthetics are drugs that suppress pain in blocking impulse conduction along axons. Conduction is blocked only in neurons located near the site of administration. Basic pharmacology of local anesthetics. There are two major groups of local anesthetics, the esters and amides. The ester type anesthetics, represented by procaine or the novocaine, contain an ester linkage in their structure. In contrast, the amide type agents, represented by lidocaine or the xylocaine, contain an amide linkage. The ester type agents and amide type agents differ in two important ways. First, method of inactivation, and second, promotion of allergic responses. Mechanism of action. Local anesthetics stop axonal conduction by blocking sodium channels in axonal membrane. Selectivity of anesthetic effects. Small, non-myelinated neurons are blocked more rapidly than large myelinated neurons. Because of this differential sensitivity, some sensations are blocked sooner than others. Specifically, perception of pain is lost first, followed in order by perception of cold, warmth, touch, and deep pressure. Ester type anesthetics, example of procaine, occasionally cause allergic reactions and are inactivated by esterases in the blood. Amide type anesthetics, like lidocaine, rarely cause allergic reactions and are inactivated by enzymes in the liver. Cocaine was our first local anesthetics. It is an ester type anesthetic. In addition to causing local anesthesia, cocaine has pronounced effects on the sympathetic and the central nervous systems. The sympathetic and the CNS effects are due largely to blocking the uptake of norepinephrine by adrenergic neurons. Time course of local anesthesia. Onset of anesthesia occurs most rapidly with anesthetics that are small, lipid-soluble, and non-ionized at physiologic pH. Termination of local anesthesia is determined in large part by regional blood flow. Co-administration of epinephrine, a vasoconstrictor, will prolong anesthesia. Local anesthetics can be absorbed in amounts sufficient to cause systemic toxicity. Principal concerns are cardiac dysrhythmias and CNS effects such as seizures, unconsciousness, and coma that can occur. The risk of systemic toxicity from topical anesthetics applied to the skin can be reduced by first, using the smallest amount needed, second, avoiding application to large areas, third, avoiding application to broken or irritated skin, and fourth, avoiding strenuous exercise and use of dressings or heat pads, which can increase absorption by increasing skin temperature. So these are the topical anesthetics. First, we have the benzocaine, cocaine, lidocaine, declunine, lidocaine, bromoxine, prilocaine, and the tetracaine. General anesthetics. General anesthetics are drugs that produce unconsciousness and a lack of responsiveness to all painful stimuli. General anesthetics can be divided into two groups. First, the inhalation anesthetics, and second, intravenous anesthetics. When considering the anesthetics, we need to distinguish between the terms analgesia and anesthesia. Analgesia refers specifically to loss of sensibility to pain. In contrast, anesthesia refers not only to loss of pain but to loss of all other sensations such as touch, temperature, taste, and to loss of consciousness as well. An ideal inhalation anesthetic would produce unconsciousness, analgesia, muscle relaxation, and amnesia. The term balanced anesthesia refers to the use of several drugs to ensure that induction of anesthesia is smooth and rapid and that analgesia and muscle relaxation are adequate. The minimum alveolar concentration, or the MAC, of an inhalation anesthetic is defined as the minimum concentration of drug in alveolar air that will produce immobility in 50% of patients exposed to a painful stimulus. A low MAC indicates high anesthetic patency. Inhalation agents works by enhancing transmission at inhibitory synapses and by inhibiting transmission at excitatory synapses. Inhalation anesthetics are eliminated almost entirely in the expired air. As a rule, they undergo minimal hepatic metabolism. The principal adverse effects of general anesthetics are depression of respiration and cardiac performance. Malignant hyperthermia is a rare genetically determined life-threatening reaction to general anesthetics. Co-administration of succinylcholine, a neuromuscular blocker, increases the risk of the reaction. By enhancing analgesia, opioids reduce the required dosage of general anesthetic. By enhancing muscle relaxation, neuromuscular blockers reduce the required dosage of general anesthetic. Nitrous oxide differs from other general anesthetic in two important ways. First, it has a very high MAC and therefore cannot be used alone to produce general anesthesia. And second, it has high analgesic potency and therefore is frequently combined with other general anesthetics to supplement their analgesic effects. Propofol, a rapid-acting agent with an ultra-short duration, is widely used alone for diagnostic procedure and combined with an inhalation anesthetic as a component of balanced anesthesia. Ketamine is an IV anesthetic that produces a state known as dissociative anesthesia. Patients recovering from ketamine may experience adverse psychologic reactions. Opioid analgesics, opioid antagonists, and non-opioid centrally acting analgesics. Analgesics are drugs that relieve pain without causing loss of consciousness. Opioids are the most effective analgesics available. There are three major classes of opioid receptors, designated mu, kappa, and DOTA. Morphine and other pure opioids agonists relieve pain by mimicking the actions of endogenous opioid peptides, primarily at mu receptors and partly at kappa receptors. Opioid-induced sedation and euphoria can complement pain relief. Because opioids produce euphoria and other desirable subjective effects, they have a high liability for abuse. Respiratory depression is the most serious adverse effect of the opioids. Other important adverse effects are constipation, urinary retention, orthostatic hypotension, emesis, meiosis, birth defects, and elevation of ICP. Because of first-fast metabolism, oral doses of morphine must be larger than parenteral doses to produce equivalent analgesic effects. Because the blood-brain barrier is poorly developed in infants, these patients need smaller doses of opioids, adjusted for body weight, than do older children and adults. With prolonged opioid use, tolerance develops to analgesia, euphoria, sedation, and respiratory depression, but not deconstipation and meiosis. Cross-tolerance exists among the various opioid agonists, but not between opioid agonists and general CNS depressants. With prolonged opioid use, physical dependence develops. An abstinence syndrome will occur if the opioid is abruptly withdrawn. In contrast to the withdrawal syndrome associated with general CNS depressants, the withdrawal syndrome associated with opioids, although unpleasant, is not dangerous. To minimize symptoms of abstinence, opioids should be withdrawn gradually. Precautions to opioid use include pregnancy, labor and delivery, head injury, and decreased respiratory reserve. Patients taking opioids should avoid alcohol and other CNS depressants because these drugs can intensify opioid-induced sedation and respiratory depression. Patients taking opioids should avoid anticholinergic drugs such as antihistamines, tricyclic antidepressants, atropine-like drugs, because these drugs can exacerbate opioid-induced constipation and urinary retention. Opioid overdose produces a classic triad of signs: coma, respiratory depression, and pinpoint pupils. All strong opioid agonists are essentially equal to morphine with regard to analgesia, abuse liability, and respiratory depression. Use of pyridine should be avoided so as to prevent accumulation of normipyridine, a toxic metabolite. Pentazocine and other agonist-antagonist opioids produce less analgesia than morphine and have a lower potential for abuse. With agonist-antagonist opioids, there is a ceiling to respiratory depression. If given to a patient who is physically dependent on pure opioids agonists, an agonist-antagonist will precipitate withdrawal. Pure opioid antagonists act as antagonists at mu receptors and kappa receptors. The naloxone and other pure opioids antagonists can reverse respiratory depression, coma, and analgesia and other effects of pure opioids agonists. The only exception is methylatrexone, which doesn't cross the blood-brain barrier. Pure opioids antagonists are used primarily to treat opioids overdose. Two agents, methylatrexone and naloxone, are used for opioid-induced constipation and another, alvimopan, for opioid-induced ileus. If administered in excessive dosage to an individual who is physically dependent on opioid agonists, naloxone will precipitate an immediate withdrawal reaction. Opioid dosage must be individualized. Patients with a low tolerance to pain or with extremely painful conditions need high doses. Addiction is a primary chronic disease characterized by an individual pathologically pursuing rewards or relief by substance abuse and other behaviors. Physical dependence and addiction are not the same. Abuse is defined as drug use that is inconsistent with medical or social norms. Because of excessive and inappropriate fears about addiction and abuse, providers frequently prescribe less pain medication than patients need, and nurses frequently administer less medication than was prescribed. Pain management in patients with cancer. Cancer pain can relieve in 90% of the patients. Despite the availability of effective treatments, cancer pain goes unrelieved in a large number of patients. Barriers to pain relief include inadequate prescriber training, fears of addiction, and a healthcare system that until recently has put a low priority on pain management. Pain is a personal, subjective experience that encompasses not only the sensory perception of pain but also the patient's emotional and cognitive responses to both the painful sensation and the underlying disease. Pain has two major forms: nociceptive pain, which results from injury to tissues, and neuropathic pain, which results from injury to peripheral nerves. Three groups of analgesics are employed: non-opioid analgesics or NSAIDs and acetaminophen, opioid analgesics, and adjuvant analgesics. Adjuvant analgesics can be used at any time. If pain is already intense, treatment can start with an opioid rather than trying a non-opioid first. NSAID produce their effects by inhibiting cyclooxygenase or COX, an enzyme with two basic forms, COX-1 and COX-2. Most NSAIDs inhibit COX-1 and COX-2. A few NSAIDs are COX-2 selective. Principal adverse effects of the NSAIDs are GI injury, acute renal failure, and bleeding. In addition, all NSAIDs except aspirin pose a risk of thrombotic events. Opioids are the most effective analgesics available, and hence are the primary drugs for treating moderate to severe cancer pain. Opioids are especially effective against nociceptive pain. Efficacy against neuropathic pain is limited. Opioid analgesics relieve pain by mimicking the actions of endogenous opioid peptides such as enkephalins, dynorphins, endorphins, primarily at mu receptors in the CNS. The opioids fall into two major groups: pure or full agonists, such as morphine, and agonist antagonists, such as butorphanol. For most patients, opioids should be given on a fixed schedule ATC with additional doses provided for breakthrough pain. Oral administration is preferred for most patients, thus dermal administration is a good alternative. Intramuscular opioids are painful and should be avoided. Addiction to opioids is very rare in people taking these drugs to relieve pain. Misconceptions about opioid addiction are a major cause for undertreatment of cancer pain. Accordingly, we must correct this misconception by teaching physicians, nurses, patients, and family members that first, addiction is not the same as physical dependence. Second, addiction is very rare in therapeutic setting. Respiratory depression is the most dangerous side effect of the opioids. Fortunately, significant respiratory respiratory depression is rare. Respiratory depression is increased by drugs with CNS depressants such as alcohol, barbiturates, benzodiazepines. Accordingly, combining these agents should be avoided. Severe respiratory depression can be reversed with naloxone or Narcan, an opioid agonist. However, because of excessive naloxone, will reverse opioid analgesia and precipitate withdrawal. Dosage must be titrated carefully. Use of mipyridine, a pure opioid agonist, should be avoided because a toxic metabolite can accumulate. Antagonist opioids must not be given to patients taking pure opioids agonists because doing so could reduce analgesia and precipitate withdrawal. Adjuvant analgesics can enhance analgesia from opioids, help manage concurrent symptoms that exacerbate pain, and the treat side effects caused by opioids. In addition, several adjuvants are effective against neuropathic pain. Adjuvant analgesics are given to complement the effects of opioids. Accordingly, these drugs are employed in combination with opioids, not as substitute.
Drugs for headache. Migraine is a neurovascular disorder involving dilation and inflammation of intracranial arteries. Anti-migraine drugs are used in two ways, abortive and prophylactic. The goal of abortive therapy is to eliminate headache pain and associated nausea and vomiting. The goal of prophylactic therapy is to reduce the incidence and intensity of migraine attacks.
There are two kinds of drugs for abortive therapy: non-specific analgesics, like aspirin-like drugs and opioids, and migraine-specific drugs such as triptans and ergoalkaloids. Aspirin-like analgesics such as acetaminophen, aspirin, naproxen are effective for abortive therapy of mild to moderate migraine. Opioid analgesics such as butorphanol, miferidine are reserved for severe migraine that has not responded to other drugs. Triptans such as sumatriptan are first-line drugs for abortive therapy of moderate to severe migraine. Triptans activate 5-HT1B or 1D receptors and thereby constrict intracranial blood vessels and suppress release of inflammatory neuropeptides. All triptans are available in oral formulations, which have a relatively slow onset. Two triptans, sumatriptan and zolmitriptan, are available in fast-acting formulations, either nasal spray, sub-Q injections, or both. Triptans can cause coronary vasospasm and hence are contraindicated for patients with ischemic heart disease, prior MI, or uncontrolled hypertension. Ergotamine is a second-line drug for abortive therapy of severe migraine. Overdose with ergotamine can cause ergotism, a serious condition characterized by severe tissue ischemia secondary to generalized constriction of peripheral arteries. Ergotamine must not be taken routinely because physical dependence will occur. Ergotamine can cause uterine contraction and must not be taken during pregnancy. Prophylactic therapy is indicated for migraineurs who have frequent attacks, 2 or more a month, especially severe attacks or attacks that do not respond adequately to abortive agents. Propranolol, divalprox, and amitriptyline are preferred drugs for migraine prophylaxis. Estrogen supplements can help prevent menstrual-associated migraines. Antipsychotic agents and their use in schizophrenia. Schizophrenia is a principal indication for antipsychotic psychotic drugs, although many are also used for bipolar disorder. It is a chronic illness characterized by disordered thinking and reduced comprehension of reality. Positive symptoms include hallucinations, delusion, and agitation. Negative symptoms include blunted affect, poverty of speech, and social withdrawal. Cognitive dysfunction manifests as disordered thinking, reduced ability to focus attention, plus learning and memory difficulties. Antipsychotic drugs fall into two major groups: first generation antipsychotics or the FGAs and second generation antipsychotics or the SGAs. Drugs in both groups are equally effective at treating schizophrenia. Despite initial impressions, the SGAs are no safer than FGAs. They simply produce different adverse reactions. Whereas FGAs carry a high risk of extrapyramidal symptoms or EPS, the SGAs carry a high risk of metabolic effects. Therapeutic responses to antipsychotic drugs develop slowly, often several months, to exert maximal effects. First generation antipsychotics are thought to relieve symptoms of schizophrenia by causing strong blockage of T2 receptors. Second generation antipsychotics are thought to relieve symptoms of schizophrenia by causing moderate blockage of D2 receptors and strong blockage of 5-HT receptors. The major concern with FGAs is the production of EPS, which can occur early in treatment, acute dystonia, Parkinsonism, and akathisia, or late treatment, tardive dyskinesia. Acute dystonia and Parkinsonism respond to anticholinergic drugs like benzodiazepine. Akathisia is harder to treat but may respond to anticholinergic drugs, benzodiazepines, or beta blockers. Tardive dyskinesia or TD has no reliable treatment. For patients with severe TD, switching to an SGA may help. The risk of early EPS is much greater with potency FGAs than with low potency FGAs, whereas the risk of TD is equal with both groups. The risk of sedation, orthostatic hypotension, and anticholinergic effects is greater with the low potency FGAs than with the high potency FGAs. FGAs can cause neuroleptic malignant syndrome characterized by muscular rigidity, high fever, and autonomic instability. Levodopa can counteract with the beneficial effects of FGA drugs and vice versa because levodopa activates dopamine receptors whereas FGAs block dopamine receptors. Haloperidol or Haldol is a prototype of the high-potency FGAs. Second generation antipsychotics differ from FGAs in three important ways. First, they block the receptors for serotonin in addition to receptors for dopamine. Second, they carry a lower risk of EPS including TD, and they carry a high risk of serious metabolic effects like weight gain, diabetes, and dyslipidemia that can lead to adverse cardiovascular events and premature death. Among the SGAs, the risk of metabolic effects is greatest with clozapine and olanzapine. Clozapine, the first SGA, is the most effective antipsychotic drug available. It can cause potentially fatal aganocylcytosis. Hence, regular blood tests are mandatory and the drug should be reserved for patients who have not. Antidepressants. The principal symptoms of major depressions are depressed mood and loss of pressure or interest in one's usual activities and pastimes. Patients with mild depression can be treated equally well with antidepressant drugs or psychotherapy. Patients with severe depression respond better to a combination of drugs plus psychotherapy than other intervention alone. Patients with depression often think about or attempt suicide during treatment with antidepressants, especially initially the risk of suicide may increase. To reduce the risk of suicide, patients should be followed closely by family members, caregivers, and the prescriber. Suicide risk is greatest in children and young adults. All antidepressants appear equally effective. Differences relate primarily to side effects, drug interactions, and cost. SSRIs block uptake of serotonin and thereby intensify transmission of serotonergic synapses. Over time, this induces adaptive cellular responses that are ultimately responsible for relieving depression. SSRIs have two major advantages over TCAs. They cause fewer side effects and are safer when taken in overdose. Most SSRIs have stimulant properties and hence can cause insomnia and agitation. This contrasts with TCAs, which cause sedation. SSRIs can cause serotonin syndrome, especially when combined with MAOIs. Symptoms include agitation, confusion, hallucination, hyperflexia, tremor, and fever. SNRIs, like SSRIs, can cause serotonin syndrome. TCA blocks reuptake of NE and 5-HT and thereby intensify transmission at noradrenergic and serotonergic synapses. Over time, this induces adaptive cellular responses that are ultimately responsible for relieving depression. The most common adverse effects of TCAs are sedation, orthostatic, hypotension, and anticholinergic effects, such as dry mouth and constipation. The most serious adverse effect of TCAs is cardiotoxicity, which can be lethal if an overdose is taken. Because TCAs can cause a hypertensive crisis if combined with MAOI. Accordingly, the combination is generally avoided. MAOIs increase neuronal stores of NE and 5-HT and thereby intensify transmission at noradrenergic and serotonergic synapses. Over time, this induces adaptive cellular responses that are ultimately responsible for relieving depression. MAOIs are as effective as SSRIs and TCAs but are potentially more hazardous. MAOIs are first choice drugs only for patients with atypical depression. Like SRIs and SNRIs and like TCAs, MAOIs can cause direct CNS stimulation. Like TCAs and like SSRIs or SNRIs, MAOIs cause orthostatic hypotension. MAOIs must not be combined with SSRIs, SNRIs, or other serotonergic drugs because serotonin syndrome could result. ECT relieves depression faster than antidepressant drugs and often helps when antidepressants have failed. ECT as practiced today is safer and less traumatic than in the past owing to adjunctive use of first a short-acting IV anesthetic such as propofol to sedate to produce unconsciousness, and second, a short-acting muscle relaxant or the succinylcholine to prevent convulsions. Drugs for bipolar disorder. BPD or the bipolar disorder is treated with three kinds of drugs: mood stabilizers, antipsychotic drugs, and antidepressant. Mood stabilizers are drugs that relieve symptoms during manic and depressive episodes and prevent recurrence of manic and depressive episodes, and third, do not worsen symptoms of mania or depression and do not accelerate the rate of cycling. Antipsychotic drugs are used acutely to treat manic episodes and long-term to help stabilize mood. Benefits occur in patients with and without psychotic symptoms. In patients with bipolar depression, using an antidepressant alone may include mania, although the risk appears lower than previously believed. Nonetheless, to minimize risk of mania, antidepressants should not be routinely used alone. Rather, they should be combined with mood-stabilizing drugs. Lithium and valproate are the preferred mood stabilizers for bipolar disorders. To minimize the risk of toxicity, lithium levels must be monitored. Common side effects that occur at therapeutic lithium levels include tremor, goiter, and pylorrhea. Lithium may be teratogenic and hence should be avoided during the first trimester of pregnancy. Also, unless the benefits outweigh the risk, lithium should be avoided during the second and third trimester too. A reduction in sodium levels will reduce lithium excretion, causing lithium to accumulate, possibly to toxic levels. Patients must maintain normal sodium intake and levels. Lithium levels can be increased by diuretics, especially thiazides, and by several non-steroidal anti-inflammatory drugs.
Hello guys, now we'll be talking about sedative hypnotic drugs. So in the next slide, we will be discussing or I will be talking about it. So come on, let's listen now. So the sedative hypnotics are drugs that repress the central nervous system or CNS function. With some of these drugs, CNS depression is more generalized than with others. The sedative hypnotics are used primarily for two common disorders, which are anxiety and insomnia. Agents given to relieve anxiety are known as anti-anxiety agents or anxiolytics. So agents given to promote sleep are known as hypnotics. The distinction between anti-anxiety effects and hypnotic effects is often a matter of dosage. So typically, sedative hypnotics relieve anxiety in low doses and induce sleep in higher doses. There are three major groups of sedative hypnotics. First one is barbiturates, second one is benzodiazepine, third one is benzodiazepine-like drugs. So the barbiturates were introduced in the early 1900s, the benzodiazepines in 1950s, and the benzodiazepine-like drugs in the 1990s. Although barbiturates were widely used as a sedative hypnotics in the past, they are rarely used for this purpose today, having been replaced by the newer drugs. Before the benzodiazepines became available, anxiety and insomnia were treated with barbiturates and other general CNS depressants drugs with multiple undesirable qualities. Now, we will be talking about benzodiazepines. So, along with the newer benzodiazepine receptor agonists, are drugs of first choice for anxiety and insomnia. In addition, these drugs are used to induce general anesthesia and to manage seizures, disorders, muscle spasm, and withdrawal from alcohol. The popularity of the benzodiazepines as sedatives and hypnotic stems from their superiority over the alternatives, barbiturates, and other general CNS depressants. The benzodiazepines are safer than the general CNS depressants and have a lower potential for abuse. In addition, benzodiazepines produce less tolerance and physical dependence and are subject to fewer drug interaction. Because all of the benzodiazepines produce nearly identical effects, we will consider the family as a group rather than selecting a representative member as a prototype. So for the overview of pharmacologic effects, practically all responses to benzodiazepines result from actions in the CNS. Benzodiazepines have few direct actions outside the CNS. All of the benzodiazepines produce a spectrum of responses. However, because of the pharmacokinetic differences, individual benzodiazepines may differ in clinical applications. First one is in the cardiovascular system. When taken orally, benzodiazepines have almost no effect on the heart and blood vessels. In contrast, when administered intravenously, even in therapeutic doses, benzodiazepine can produce profound hypotension and cardiac arrest. While in respiratory system, in contrast to the barbiturates, the benzodiazepines are weak respiratory depressants when taken alone in therapeutic doses. Benzodiazepines produce little or no depression of respiration and with toxic doses. Respiratory depression is moderate at most. And now we will be talking about pharmacokinetics. For its absorption and distribution, most benzodiazepines are well absorbed following oral administration because of their high lipid solubility. Benzodiazepines readily cross the blood-brain barrier to reach sites in CNS. While the metabolism, most benzodiazepines undergo extensive metabolic alterations. With few exceptions, the metabolites are pharmacologically active. As a result, responses produced by administering a particular benzodiazepine often persist long after the parent drug has disappeared. For the time course of action, benzodiazepines differ significantly from one another with respect to time course. Specifically, they differ in onset and duration of action and tendency to accumulate with repeated dosing. Because all benzodiazepines have essentially equivalent pharmacologic actions, selection among them is based largely on differences in time course. For example, if patient needs medication to accelerate falling asleep, a benzodiazepine with a rapid onset would be indicated. For its therapeutic uses, the benzodiazepines have three principal indications. First one is anxiety, second one is insomnia, and third one is seizure disorders. In addition, they are used as preoperative medications and to treat muscle spasm and withdrawal from alcohol. Although all benzodiazepines share the same pharmacologic properties and therefore might be equally effective for all applications. Not every benzodiazepine is actually employed for all potential uses. And now, for the therapeutic uses of benzodiazepines in anxiety, benzodiazepines are drugs of first choice for acute anxiety. Although all benzodiazepines have anxiolytic actions, only 6 are marketed for this. Anxiolytic effects result from repressing neurotransmission in the limbic system and cortical areas. And for the therapeutic uses of benzodiazepines in insomnia, benzodiazepines are preferred drugs for insomnia. These drugs decrease latency time to falling asleep, reduce awakenings, and increase total sleeping time. The role of benzodiazepines in managing insomnia. So, do you know that there are benzodiazepine-like drugs? There are 3 benzodiazepine-like drugs are available, which are the zolpidem, zaleplon, and azopiclone. All 3 are preferred agents for insomnia. They are not indicated for anxiety. These drugs are structurally different from benzodiazepine, but nonetheless share the same mechanism of action. They all act as agonists at the benzodiazepine receptor site on the GABA receptor chloride channel complex. Like the benzodiazepines, these drugs have a low potential for tolerance, dependence, and abuse, and are classified as Schedule 4 substances. Ramelson, which is a melatonin agonist. A ramelson or Roseram is a hypnotic with a unique mechanism of action. Activation of receptors for melatonin. Its therapeutic use has a rapid onset in about 30 minutes and is short duration, and hence is good for inducing sleep but not maintaining sleep. Its mechanism of action activates receptors for melatonin, specifically the MT1 and MT2 subtypes, which are key mediators of the normal sleep-wakefulness cycle. Sleep promotion derives primarily from activating the MT1 receptors, and their motion's adverse effects is very well tolerated. In clinical trials, the incidence of the adverse effects was nearly identical to that placebo. The most common side effects are somnolence and dizziness and fatigue. And to discuss what barbiturates is, the barbiturates have been available for more than 100 years. These drugs cause relatively non-selective depression of CNS function and are prototypes of the general CNS depressants. Because they depress multiple aspects of CNS function, barbiturates can be used for daytime sedation, induction of sleep, suppression of seizures, and general anesthesia. The barbiturates fall into three groups: ultra-short-acting, short to intermediate acting, and long-acting based on duration of action. Their duration of action is inversely related to their lipid solubility. Barbiturates with the highest lipid solubility have the shortest duration of action. Conversely, barbiturates with the lowest lipid solubility have the longest duration. Duration of action influences the clinical application of barbiturates. The ultra-short-acting agents such as methotrexate are used for indication of anesthesia. The short to intermediate-acting agents such as psychobarbital are used as sedatives and hypnotics. The long-acting agents such as phenobarbital are used primarily as anti-seizure drugs. And now we will be discussing the management of anxiety disorders. So are you ready to listen now? Come on, let's go to the next slide. So what is anxiety? Anxiety is an uncomfortable state that has both psychological tachycardia, sweating and cold, clammy hands, and physical components. The physiologic component can be characterized with terms such as fear, apprehension, dread, and uneasiness. The physical components manifest as tachycardia, palpitations, trembling, dry mouth, sweating, weakness, fatigue, and shortness of breath. In addition, anxiety is a nearly universal experience that often serves an adaptive function. When anxiety is moderate and situationally appropriate, therapy may not be needed or even desirable. In contrast, when anxiety is persistent and disabling, intervention is clearly indicated. Now we will be talking about generalized anxiety disorder or GAD. Its characteristics is a chronic condition characterized by uncontrollable worrying. Of all anxiety disorders, GAD is the least likely to remit. Most patients with GAD also have another psychiatric disorder, usually depression. Its treatment can be managed with non-drug therapy and with drugs. Non-drug approaches include supportive therapy, cognitive behavioral therapy or CBT, biofeedback, and relaxation training. So there are anxiolytic drugs used for anxiety. First one is buspirone. Actions and therapeutic use. Buspirone is an anxiolytic drug that differs significantly from the benzodiazepines. Most notably, buspirone is not a central nervous system or CNS depressant. For treatment of anxiety, buspirone is as collective as the benzodiazepines. Benzodiazepines are second-choice drugs for anxiety. Benefits derive from enhancing responses to GABA, an inhibitory neurotransmitter. Onset of benefits is immediate and margin safety is high. Now we will be talking about panic disorder. So panic symptoms reach a peak in a few minutes and then dissipate within 30 minutes. Many patients go to an emergency department because they think that they are having a heart attack. So panic disorder is characterized by recurrent, intensely uncomfortable episodes known as panic attacks. A panic attack is an abrupt surge of intense fear of intense discomfort during which four or more of the following are present: palpitations, pounding heart, or racing heartbeat, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal stress, etc. For the panic attacks treatment, between 70% and 90% of patients with panic disorder respond well to treatment. Two modalities may be employed: drug therapy and CBT. Combining drug therapy with CBT is more effective than other modality alone. As a rule, patients experience rapid and significant improvement. Drug therapy helps suppress panic attack, while CBT helps patients become more comfortable with situations and places they have been avoiding. And for its antidepressants, panic disorder responds well to all four classes of antidepressants: the SRIs, the SNRIs, tricyclic antidepressants, and monoamine oxidase inhibitors. Antidepressants and monoamine oxidase inhibitors, with all four, full benefits take 6 to 12 weeks to develop. Owing to better tolerability, SSRIs are generally preferred. After that, we will now proceed to the central nervous system stimulants and attention deficit or hyperactivity disorder. Amphetamines. The amphetamine family consists of amphetamine, dextroamphetamine, methamphetamine, and lisdexamfetamine. All are powerful CNS stimulants. In addition to their CNS actions, amphetamines have a significant peripheral actions or actions that can cause cardiac stimulation or vasoconstriction. The amphetamines have a high potential use for abuse. For its chemistry, dextroamphetamine and levamphetamine are molecules with an asymmetric carbon atom. As a result, amphetamines can exist as mirror images of each other. Such compounds are termed optical isomers and enantiomers. Dextroamphetamine and levamphetamine both contain the same atomic components, but those components are arranged differently around the asymmetric carbon. For the methamphetamine is simply dextrose amphetamine with an additional methyl group. The amphetamines act primarily by causing release of norepinephrine and dopamine, and partly by inhibiting reuptake of both transmitters. These actions take place in the CNS and in peripheral nerves. Most pharmacologic effects result from release of NE. So, amphetamine has a pharmacologic effects on our central nervous system and on our cardiovascular system. And now, we'll be talking about substance use disorders and its basic considerations. So, if you're wondering what drug abuse is, drug abuse can be defined as using a drug in a fashion inconsistent with medical or social norms. Traditionally, the term also implies drug usage that is harmful to the individual or society. As we shall see, although we can give abuse a general definition, deciding whether a particular instance of drug abuse constitutes abuse is often difficult. Whether drug use is considered abuse depends, in part, on the purpose for which drug is taken. Not everyone who takes large doses of psychoactive agents has a disorder. For example, we do not consider it abuse to take large doses of opioids long-term to relieve pain caused by cancer. However, we do consider it abuse for an otherwise healthy individual to take those same opioids in the same doses to produce euphoria. Another example is substance use disorder. It is defined as a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problems. Please note that nowhere in this definition is SUD equated with physical dependence. As discussed elsewhere in this chapter, although physical dependence can contribute to addictive behavior, it is neither necessary nor sufficient for addiction to occur. So there are factors that contribute substance use disorder. First one is reinforcing properties of drugs, physical dependence, physiologic dependence, social factors, drug availability, and lastly, vulnerability of the individual. Now, we are going to proceed with the disorders specifically on alcohol. So alcohol is the most commonly used and abused psychoactive agent in the United States. Although alcohol does not have some therapeutic applications, the drug of interest is primarily for its non-medical use. When consumed in moderation, alcohol prolongs life and reduces the risk of dementia and cardiovascular disorders. Conversely, when consumed in excess, alcohol does nothing but diminish life in both quantity and quality. In approaching our study of alcohol, we begin by discussing the basic pharmacology of alcohol, and then we discuss alcohol use disorder and the drugs employed for treatment. And now, for the basic pharmacology of alcohol, central nervous system effects has four types: the acute effects, chronic effects, and impact of cognitive function, and effect on sleep. To discuss the acute effects, alcohol has two acute effects on the brain: the general depression of central nervous system function and activation of the reward circuit. For many years, we believed that alcohol simply dissolved into the neuronal membrane, thereby disrupting the ordered arrangement of membrane phospholipids. So, for the chronic effects, when consumed and chronically and in excess, alcohol can produce severe neurologic and psychiatric disorders. Injury to the CNS is caused by the direct actions of alcohol and by the nutritional deficiency often seen in chronic and heavy drinkers. Impact on cognitive function. Low to moderate drinking helps preserve cognitive function in older people and may protect against development of dementia. And lastly, the effect on sleep. Alcohol is commonly used as a sleep aid. It actually disrupts sleep. Drinking can alter sleep cycles, decrease total sleeping time, and reduce the quality of sleep. In addition, alcohol can intensify snoring and exacerbate obstructive sleep apnea. And now, for the last topic that we will be discussing for the substance use disorders, specifically and nicotine and smoking. Cigarette smoking remains the greatest single cause of preventable illness and premature death. In the US, smoking kills more than 480,000 adults each year, about 1 of every 5 deaths. Around the world, tobacco kills more than 6 million people each year. On average, male smokers die 13.2 years prematurely, and female smokers die 14.5 years prematurely. According to the Center for Disease Control and Prevention, most deaths result from lung cancer, coronary heart disease, and chronic airway obstruction. Not only do cigarettes kill people who smoke, but every year, through secondhand smoke, cigarettes kill about 4 to 1,000 non-smoking Americans and about 600,000 non-smokers worldwide. The effects of the nicotine results from actions on nicotinic receptors. Whether these receptors are activated or inhibited depends on nicotine dosage. Low doses activate nicotinic receptors, high doses block them. The amount of nicotine received from cigarettes is relatively low. Accordingly, cigarette smoking causes receptor activation. And that was the basic pharmacology of nicotine and its mechanism of action. And for its pharmacokinetics, absorption of nicotine depends on whether the delivery system is a cigarette or e-cigarette, a cigar or smokeless tobacco. Nicotine in cigarette smoke is absorbed primarily from the lungs. When cigarette smoke is inhaled, between 90% and 98% of nicotine in the lungs enter the blood. Unlike nicotine in cigarette smoke, nicotine in cigarette smoke is absorbed primarily from the mouth, as in nicotine in smokeless tobacco. And now, we're done discussing every topics from our pharmacology. I hope you learned a lot and thank you for watching our video. Thank you!